Good evening, good morning, good afternoon, depending on the area where you are watching this webinar. It's a great pleasure to give a new webinar about grafting procedures. And today we want to focus on a very specific item of grafting procedure. This is the use of absorbable membranes for the guided bone regeneration. Implantology can be very simple. When we have enough bone in mesodistal direction, when there is enough bone width, we have a quite nice and successful therapy for replacing missing teeth. With a success rate of 98% without harming the adjacent teeth, we are able to just restore a crown with a very low trauma therapy. However, as you all know, life can be more complicated. So we have to handle with defects. It can be a horizontal defect. There can be some operations in the past that cost a lot of bone. Sometimes we have extended areas that need to be augmented. We have defects vertically in the sinus or of the alveolar crest. Sometimes there just have been no bone formed after the tooth extraction, or a combined horizontal and vertical defect. And we have to decide which technique we can use for predictable and reliable bone regeneration. When we think about the aim of biological bone reconstruction, of course, the first thing you can consider is that we want to have sufficient bone volume in both vertical dimensions and horizontal dimensions. And we know that we need to have at least 1 millimeter of bone on the oral aspect and 2, maybe even better, 3 or 4 millimeters of bone of the buccal aspect. However, we want vital bone in this area. No soft tissue encapsulated bone substitute material, not dead bone blocks, because only the vital bone matrix is able to achieve a high long-term stability that allows for a very predictable outcome. And we want to do safe therapies with predictable outcome, because we don't want to put our patients on risk of complications. So the complication rate should be very low. And also, this is a major aspect for our patients. They don't want us to make experiments with them. We want to have high patient satisfaction. But when we ask our patient what is the most important aspect for them, and I have this situation very often when I offer to solve a problem with an autogenous bone block or bone substitute material, the patients are expecting minimal trauma therapy, meaning that whenever they can avoid donor side morbidity, such as pain, swelling, and the risk of nerve injuries, of course, they will be more into an alternative therapy than putting themselves on risk of a complication. So for them, it's a very important aspect to have the lowest pain, the lowest trauma, the lowest complication rate you can get. When we think about the prerequisite for successful dental implant treatment, we need to have vital bone matrix around our implants, because only this direct contact, the bone to implant contact, allows for the capability to install a crown, to externally load the implant for prosthetic aspects. When we look at this specific tissue, we know that there are osteoblasts, osteocytes, and osteoclasts, but it's a steady remodeling. So the bone is a very vital tissue that reacts to different loading situations. And also in terms of regeneration and healing, we need to support the osteoblasts because they are important to produce the bone. However, when we consider a bone defect healing, we know today that It is not the case that the osteoblasts from the surrounding areas are just invading into the defect area. We know that osteoblasts are very highly differentiated cells and then are not able to just move from one side to another. So we have to have other cells that are capable of just moving into a defect area to just support bone formation also in areas that are not in direct contact to the bone walls around the defect. And here we are talking about stem cells. The bone precursor cells are important because they are still not finally differentiated. They are able to move and they are just coming from the pre-osteoblast, from the stroma of the bone marrow. That makes the autogenous bone very interesting for bone augmentation procedures because here, depending on the technique we're using, we are able to transfer them to the recipient area. However, as you all know, we can also use bone substitute material only, and we can find on histological slides spots of new bone formation not in direct contact to pre-existing bone. And here, another cell type is very important. These are the pericytes. They are undifferentiated progenitor cells. They are located around the small blood vessels, and they are able to finally differentiate if they have a nice matrix, osteoconductive matrix, osteoinductive matrix, and an osteoinductive stimulus into their bone-producing osteoblast. This is also supporting the idea to allow for fast blood vessel invasion into the area that needs to be grafted, because without any blood vessel invasion, there will be no regeneration. So what options do we have? We can use bone splitting techniques that are based on the idea of shifting the defect from a site outside the alveolar process into a region in between two vital bone layers. So we have much better prerequisites for bone formation when we are surrounded by, of course, two vital bone walls than forming a lateral augmentation on the outside of the alveolar process. We have autografts transferring bone from the donor side to the acceptor side. And depending on the technique you're using, we can maintain the vitality of the bone. As an alternative, GBR procedures, the use of bone substitute material and membranes that allow for bone regeneration based on an osteoconductive support of the bone substitute material and volume maintaining effect of the bone substitute material, and separation of this area by the insertion of a barrier, whatever origin. It's getting more and more popular to use alloblocks for grafting procedures because here we can just focus another idea that supports bone formation, that is stability. Block augmentation provides more stability than particulated material, of course. Sinus lifts can be performed for defects in the posterior maxilla. Here we have very good prerequisites because we are placing the material inside the alveolar process. So there's no need for further stabilization, and we have very nice outcome. This is not the topic for today, for the use of bone substitute materials when we compare it to autogenous bone. We know today that we can achieve the same outcome using bone substitute materials or autogenous bone in this specific augmentation area. Then destruction osteogenesis, the idea of callus formation, distraction of the callus, and expansion of the hard and the soft tissue at the same time. These are the general aspects. Of course, we have different other techniques like sandwich osteotomy, where we can use modification of the recipient area. Nevertheless, these are the main techniques that are used in our department for peri-implant bone and soft tissue regeneration. Let me just focus a little bit on the autograft. The autograft is the only material that provides osteoconductive, osteoinductive, and osteogenic potential, meaning that we have a matrix that contains bone morphogenetic proteins that is able to osteoconductively support the regeneration, and we have the situation that we can transfer vital cells. The only thing that lacks when we talk about particulated material is volume stability or volume maintenance. This doesn't play a major role in a situation like this. Here we have a defect inside the ridge contour. So the stability is maintained by the defect itself with a mesial bone wall, a distal bone wall. So using bone chips here will end up in a quite nice outcome. Nevertheless, because we don't need volume stability of the material itself. When we go outside the ridge contour, and here we harvested a lot of bone chips when we perform the implant bed preparation, we see that there's at least 3-4 millimeters of bone chips applied on the buccal aspect. At the re-entry, the volume has tremendously been reduced. So we see that there's a loss of the volume, because when we try to use a material that is not volume stable for augmentations outside the ridge contour, outside the envelope, then this will end up in volume loss. So what can we do to stabilize the graft material? Two very simple techniques. First technique might be that we are not using the autogenous bone only, that we are combining it with some volume stable bone substitute material. This is some cerebone particles that are mixed with the autogenous bone, and then this mixture is applied on the area that needs to be grafted, on both the buccal aspect and the palate aspect. However, we are changing the system. Now we have a material that also has the capability of being fibrous encapsulated. So we know today that we need to install a membrane, absorbable membrane, non-absorbable membrane, to just separate the grafted area from the surrounding soft tissue. And then, after a healing period of 4 months, we see quite nice bone formation without this volume loss that we would have been observed after using autogenous bone only. Or another technique to get the stability from the autogenous bone itself, that we're using bone blocks, a quite rare case of a chin fracture, horizontal chin fracture after a bike accident, and a large vertical and horizontal defect in the upper front. So here we wanted to remove the osteosynthesis screws, and we used a very special technique of harvesting autogenous bone from the chin region. 2 bone blocks that are transferred to the upper front and fixed with some osteosynthesis screws, some contouring with some cerebone particles, and a membrane on top of it. And the most demanding aspect here, of course, is not the handling of the hard tissue, it's the handling of the soft tissue. That we can achieve tension-free soft tissue closure of the site. Situation directly postoperatively, so nice bone transfer from the chin to the upper front, and after undisturbed healing, we re-enter the site, and after a little reduction of the vertical height that was a little bit over-augmented here, we can install the implant with a thick bone wall on the buccal aspect. Nevertheless, when we are talking to our patients about this technique, we also have to talk about donor side morbidity, whether it's from the retromolar region, nerve injuries, compromised mouth opening, swelling, or from the chin region, where we have a risk of sensitive disturbances of the lower lip or the lower incisors for the rest of the life of the patients. Of course, we have to inform them also about alternatives to the autogenous bone. For large defects, we can use iliac bone. There's not a big problem of the sensible disturbances, but I've seen a few hip fractures. I've seen one infection of the hip. Even if we can get a lot of bone from this area and we can use it in even very compromised recipient areas, this grafting material is on risk of donor site complications. And we have to look at alternatives to the autogenous bone, which is, of course, the bone substitute material used for science grafting procedures or in standard GBR procedures for lateral and horizontal augmentation. The idea of GBR is very simple. The idea is that we are inserting a barrier, whatever origin, to separate two different compartments. One is the slowly proliferating hard tissue, the bone, and one is the very fastly proliferating soft tissue, the connective tissue around our defects. And by inserting the barrier, we allow for enough time and enough room for the defect to regenerate with the desired tissue with the bone. It's not the same like GTR. In GTR, we want to see different kinds of tissues at the end. It's more the idea that we are using this barrier technique in a closed application, in contrast to GTR, where we always have an open system and the desired tissue is natural and vital bone matrix. When we compare the use of bone substitute materials with the use of autogenous bone, we see that for the smaller defects, based on a systematic review by Trojan co-workers, there's not a compromised outcome using allogenic material, xenogenic material, or a mixture with autogenous bone. It seems to be that we also have a very reliable technique when we're using bone substitute materials. For lateral augmentations, volume stability is important, therefore the synthetic materials are not on the same level like autogenous bone or different kinds of bone substitute materials. When we look at different barrier materials, first of all, we see that if we don't place any membrane, a defect fill of 60% is not the best outcome we can achieve. After the use of a collagen-based membrane, 85% of defect fill was achieved on average. So we can say that we see some advantages of using a barrier, an external barrier for the separation of the soft tissue. It's not the case that it doesn't work at all, but when we want to see the best outcome, we have to use a membrane, whether it's collagen-based membrane, titanium foil, or non-absorbed membrane, to just make sure that we have a reduction of the soft tissue encapsulated particles and a more complete bone formation inside the defect area. Nevertheless, we also have some statements from the German Association of Dental Implantology, also from the EAO, that we should use it, that we are getting better results after the use of a barrier in between the desired compartment for bone regeneration and the surrounding soft tissue. They don't focus on the membrane material we're using, and we have non-absorbed membranes and absorbed membranes, and we will focus a little bit on these different materials. The idea of GBR procedures does not require bone substitute material. In this situation, after the application of a titanium reinforced EPTAV membrane, there's just enough space and enough time for the bone to regenerate, and there's beautiful bone formation at the end of the healing period. However, we can use autogenous bone in combination with bone substitute materials to just enhance the volume stability and the general stability of the graft, especially for vertical augmentations. So in a study by Kathmandu and co-workers, volume stable bone substitute material in combination with autogenous bone was used for vertical augmentation, and for further stabilization of the graft, a titanium reinforced EPDFE membrane was applied and fixed to stabilize the site for a healing period of 6 months. And as you can see, a nice outcome in terms of vertical augmentation, with the little comment that they installed the implants at the same time when they did the augmentation, but furtherly, of course, stabilized the grafted area. However, when we are using EPDFE membranes, we have to be aware that we are also seeing a higher rate of descensus and consecutively premature membrane removal after the membrane getting infected than after the use of collagen membranes. In this case, we see that there's a hydrophobic surface of a non-absorbed membrane. The defect area is increasing, and then just after the removal of the membrane, there's a secondary healing of the site. The same situation, even larger, with the collagen membrane, and the patient was just rinsing with chlorhexidine solution and was getting some antibiotics, application of chlorhexidine gel, and we see that the biocompatibility of this collagen membrane leads to the effect that we have a shrinkage of the exposed area, and later on a complete secondary healing above the membrane. There's a premature absorption of the matrix, because it's not the same situation that we know for a closed healing. Nevertheless, if you consider large augmentation, multiple implant installation, this membrane application was able to stabilize the grafted site and to avoid massive complication such as loss of the graft material and even compromised implant outcome. And collagen plays an active role in coagulum formation. We know that cells are attracted in the presence of collagen, and we can transfer it from human beings to human beings or from animals to human beings. And all this together with the fact that we see less complication rates after the use of a collagen membrane is leading to the idea of using collagen membranes in our daily practice to separate the graft from the surrounding soft tissue as a standard material. The big advantage of using a collagen membrane is its absorbability. There are other products that are also biodegraded, such as polylactide or polyglycolide or copolymer membranes. They have the big disadvantage, even if sometimes the healing is quite acceptable, that when they biodegrade, we see a high acidity of the tissues based on the presence of lactic acid, and this attracts inflammatory cells, leading to compromised bone formation or even bone absorption around these materials. With collagen, we have the situation that it's mainly biodegraded by specific enzymes down to the level of amino acids that can be used for rebuilding different kinds of tissues. So here, based on a native collagen, we don't see a massive change of the pH value and a more natural healing and better integration in the surrounding connective tissue than for the polylactide and polyglycolide membranes. And we can also see this when we look at the Troeltsch paper again. When we look at the barrier material PLA and PGA, we see that they have kind of acceptable defect fill, still lower than the collagen-based barrier materials, but a much higher complication rate. So I wouldn't recommend to use absorbable polylactide or polyglycolide membrane just to avoid the need of secondary operation for the removal of the membrane. And we know that we see very long-lasting and predictable results after the use of GBR procedures for lateral augmentations around implants. So in this study, after 12 to 14 years, the all-over survival rate was 92%, but no statistically significant difference between the control group, where there have been no defects at all, defect group with collagen and bovine bone substitute material, and defect group with EPDFE membrane and bovine bone substitute material used for the defect augmentation. For the EPDFE membrane group, there was even still after 12 to 14 years a slightly worse aesthetic outcome, and the authors just concluded that was the result of the initial deescences when using the non-absorbable membranes 12 to 14 years earlier in progress of implant installation. So it's a quite reliable, a quite predictable procedure to use bone substitute materials in combination with collagen membranes for lateral deescence defect augmentation. However, when we look at this case, it's a very standard case. Implant installation doesn't play a major role how many threads are open to the buccal aspect. It's more important that we get primer stability of the implant. It's a hydrophilic implant that supports the bone regeneration furtherly, application of a bovine bone substitute material, and application of a collagen membrane that doesn't provide a long barrier function. After healing period of 4 months, we see that there is some bone formation, but there's a layer of superficial soft tissue encapsulated particles. And this, of course, is not the best outcome we can see, because these soft tissue encapsulated particles that might also end up in some inflammatory response or being resorbed. We know that for the bovine bone substitute materials, once they are integrated in uniform bone tissue, they are not on risk of being completely absorbed, maintaining the volume perfectly. But if they are just soft tissue encapsulated, this idea of non-absorption is not fulfilled because they're not surrounded by uniform bone tissue. So in the upper right here, you can see that there's soft tissue encapsulation on the outline of the graft. And that was the idea, to develop new membranes for longer barrier functions. About 10 years ago, we were doing a lot of research about collagen membranes with the idea to develop a longer lasting membrane for larger but also for smaller augmentation volumes. And the factors that are influencing the barrier function are, of course, the tissue origin. Whether we are taking the collagen from the dermal area, from the peritoneum, from dura mater, from the Achilles tendon, or later on from the pericardium. It's important how we process the collagen, whether we use pressure, temperature, and also kind of physical treatment might be if we are using it in a double layer form, just to fulfill the expectation that a double layered membrane will have the double of the barrier function. However, we know today this is a biological system. So it's not the case that just a more thick membrane provides a longer barrier function. We know this from Biomed and Biomed Extend, for example. The major difference between these two membranes is the thickness, but they both show the same absorption time in different animal experiments that we have performed. Cross-linking was very popular 10 years ago. The use of chemical agents or enzymes for the cross-linking. We will focus on this. But another aspect that is also very important is the tissue interaction. High biocompatibility, that we want to have very nice tissue integration. The cell invasion is important. And the inflammatory response, when we induce a foreign body reaction, then we are seeing a much faster absorption because we have more cells that are interested in absorbing the membrane material. But also we are seeing a compromised healing sometimes because more foreign body reaction will end up in more inflammatory response that ends up in more swelling and compromised healing. So we did a lot of experiments, as I just mentioned. 2003, we published a study about the biocompatibility, and you see in the control group, the PDL fibroblast is a spindle-shaped cell, and it's almost the same shape on the bioguide membrane. On the biomed membrane, a cross-linked membrane with glutathione, we see just a few cells and no osteoblast-like cells, indicating that we have a compromised biocompatibility. In animal testing, we see that the bioguide, on the other hand, is absorbed within the first 2 to 4 weeks. Whereas the biomed membrane, the cross-link membrane, provides absorption time of 4 to 8 weeks, so a much longer barrier function, a much longer standing time. The O6 membrane is a cross-linked membrane by insertion of sugar molecules, didn't show any absorption at all within the entire healing period of 24 weeks. Nevertheless, the tissue reaction is also completely different. The bioguide membrane is very well integrated. We don't see a split formation, we see nice cells in the membrane body, whereas the biomed membrane has a split formation around the membrane body and a capsule formation. The O6 membrane, just a little bit of absorption of the most superficial layer, not completely absorbable at all within a sufficient healing period of 24 weeks. And we tried to develop cross-linked bioguide membranes. And as you see, VN means that we have applied the cross-linking technique 1 time. VN2 is 2 times, and VN3 is 3 times. We could prolong the standing time. Nevertheless, the more cross-linking we applied, the higher invasion of inflammatory cells, the more foreign body reaction, and the less tissue integration we could find. Leading to the effect that in a clinical study, there was a higher complication rate for the cross-linked collagen membrane, and interestingly, not even a better outcome regarding the bone formation. So we can say that chemically cross-linking is leading to a more compromised tissue healing. And also in a vertical augmentation study, you see a complication of autogenous bone block that was used for vertical augmentation at little descents over a cross-linked collagen membrane that was used as a barrier for xenogenic bone blocks that were used for vertical augmentation. This little exposure didn't heal secondarily, as we would expect it for a non-cross-linked membrane. It was leading to a complete inflammation of the entire tissue, and we lost 50% of the bone blocks that were covered with the cross-linked membranes, whereas we didn't lose any xenogenic bone block without additional membrane application. And we don't need to be a very smart mathematic to realize that this is a result of the cross-linking of the membrane material. So we had to look at other aspects that are important for the barrier function, and cross-linking was not longer focused for the next generation of collagen membranes, but we just went back to the tissue origin. And there was one prototype that we tested that provided a quite nice matrix in terms of barrier function and tissue integration, as well as biocompatibility. When we compare this membrane that was developed from this prototype in terms of morphology, we see that this bilayer membrane, the BioGuide membrane, consists of a lot of individual collagen strains, whereas this pericardium membrane that was used as a material with longer standing time, the pericardium, that we see completely the opposite. It's more multi-layer network of still collagen type 1 and 3. But if it is made for the heart as a shell, where the heart is bumping 100,000 times a day against, then of course the morphological structure is completely different. The biocompatibility didn't change. We see nice proliferation of cells from 3 to 7 days for both of the membranes, but in a lateral augmentation study in dogs, we see after 4 weeks not much bone formation, but very nice tissue integration. Almost complete absorption of the BioGuide, by the way, after 4 weeks. After 8 and 12 weeks, comparable blood vessel invasion, no inflammation for both. A much longer barrier function for the pericardium membrane, and that was leading after 24 weeks to the effect that we see this superficial layer of soft tissue encapsulated bone substitute material on the surface for the BioGuide group, but a thin layer of bone on the outline of the graft for the Jason and Cerebone group, indicating that we have a more complete bone formation in the entire grafted area. However, the handling properties are a bit different. The membrane is a bit more rigid, but we can use this. We can use this by also for stabilization of the graft material. We can stick it underneath the lingual soft tissue. We apply the bone substitute material in combination with some autogenous bone, and then we put a drop of saline solution on the membrane. It becomes more flexible and folds over, stabilizing the graft. Or even for lateral large augmentations, we can use the autogenous bone in combination with some cerebon, some volume stable particles for the lateral augmentation. We use a single layer of the Jason membrane for separation from the soft tissue closure, and at the re-entry after 4 months, we can still identify some area where we see the membrane. And at a 6-year follow-up, we see quite nice and stable condition, a little bit of volume loss in the area where no implant was placed, a little bit of more recession at the natural tooth, but very nice and stable conditions at the implanted areas. Also, for lateral augmentations outside the envelope, I would use some pins today for further stabilization of the graft. Nevertheless, here the idea is to use autogenous bone in combination with a volume stable bone substitute material, long-lasting pericardium membrane, soft tissue closure, implant uncovering, and nice outcome. So the idea of using a longer lasting membrane that is able to separate the soft tissue from the desired hard tissue much longer, leading to a more complete bone formation in the grafted area. Another case, remaining bone width of about 3 millimeters, so vertical augmentation inside the sinus cavity, remaining bone height of about 5 millimeters. No problem to just use cerebon particles only inside the sinus cavity, and then a mixture of autogenous bone and bovine bone substitute material for the lateral augmentation. Same procedure, single layered Jason membrane on top, soft tissue closure, and when we look at the re-entry after a healing period of 6 months, we see a smooth surface, a complete bone formation in the entire grafted area. You can feel it when you do the preparation of the soft tissue. And At the biopsy, we see that cerebrum particles, same effect that we know for bios particles, are more integrated in the surrounding hard tissue. The bone is formed on the particles and connecting the particles, but not completely absorbing the particles. When we are using a synthetic bone substitute material, there was a little perforation of the sinus membrane, so application of the adjacent membrane inside the sinus. You can see that this membrane is very thin, and the rigidity of the membrane can be used for maintaining the height inside the sinus, like a tent effect. Application of this is Maxresorb, a synthetic biphasic beta-TCP hydroxyapatite inside the sinus cavity, and in combination with autogenous bone for the lateral augmentation, same procedure, adjacent membrane on top, healing 6 months, and again a smooth surface. Again, it's a study patient. We are harvesting trephines from the augmented area. We see that there's just 1 millimeter of bone on the bottom of the left trephine. So we did the augmentation inside the sinus cavity. Only on the right trephine, you see that we also got some information from the buccal augmentation. And when we look at high magnification, we can see that after 6 months, there are some particles that are not absorbed at all, and some particles that are just starting to be completely replaced by the patient's own bone tissue. So here we have the situation that after 2 years, maybe this material will be absorbed and replaced by the patient's own bone completely. What can we furtherly do? When there's no support from the defect area, we like today to use pins, screws, whatever technique to stabilize the graft. That we keep the material in place and immobilize it. This was also accompanied by more reliable outcome by immobilization of the grafted area. The different techniques for this is a quite nice publication from the US, where just a lateral approach was used with a tunneling preparation, and then a very rigid membrane was placed underneath the periosteum and the soft tissue. And of course, you can't do this technique with a bioguide membrane, for example, because you need the rigidity of the membrane to just open up the area that needs to be augmented, bone substitute material underneath, and soft tissue closure without disturbance of the blood supply of the grafted area. And they saw very nice outcome after a healing period of 6 months. Or in vertical augmentation, a patient with a high lip line. Of course, we can use autogenous bone only, but then we have to harvest a lot of autogenous bone. We want to bring up the bone to this red dotted line here. We perform a sinus grafting with bone substitute material only, and then we are harvesting a very thin bone splint for stabilization matters and for giving the information to support bone formation in the grafted area. But there's a large gap underneath, and we are filling this gap with some bovine bone substitute material, some cerebrum particles for volume augmentation, so very nice and fast blood vessel invasion, and then a single layer of the adjacent membrane on top of it. Soft tissue closure situation before the surgery and after the surgery with the vertical augmentation inside the sinus cavity and of the alveolar process. Then after a healing period of 6 months, re-entering of the site, nice bone formation, no problem to install the implants in the 3-dimensional correct position. Again, 3 months later, implant uncovering. There was a lack of thickness of soft tissue on the buccal aspect, so we installed a mucoderm to furtherly thicken up the soft tissue on the buccal aspect. The patient was sent back to the referring dentist after implant uncovering, and the dentist provided the final crown, so quite nice outcome even after large vertical augmentation. based on the idea to furtherly stabilize the site. However, sometimes we don't need a very long barrier function. So situation like here, very thin alveolar process. So we decided to use a very special technique that we just split the bone in the crestal part, and we use this bone splint after transferring it to the buccal aspect for lateral augmentation to give the information to build bone in this area. So we applied some bone substitute material, some cerebrum particles in between, and then we use the membrane. In this indication, we don't need a very long barrier function because the exposed area is very limited, and we want to see very fast blood vessel ingrowth to support the healing of the autogenous bone. Here we are using another membrane, the cold protect membrane, that provides a more compact layer to separate the soft tissue and some pores to allow for blood vessel ingrowth. It's more like the Biogap membrane than the Jason membrane because it's a collagen that is based on a dermal donor tissue. Interestingly, we can also find some blood vessels in these pores. However, the absorption time of the membrane is much lower than we know for the Jason membrane. So the idea is to make it a little thicker to allow for the same handling properties like the Jason membrane, but using it in indications where we don't need a longer barrier function. Situation after healing period of 6 months, so no problem to install the implants in the 3-dimensional correct position, and quite nice bone outcome in the grafted area. Or another indication that is cancer of the oral cavity with some metastasis. So after irradiation therapy, resection of the mandible and neck dissection. And in this situation, we like to use microvascular grafts for the rehabilitation because we can just perform an anastomosis of the blood vessels and allow for blood supply directly after the surgery. Using fibular grafts, or if the prerequisites are not ideal, or we need 2 skin petals like in the patient I'm just presenting, we can also go to the scapular area and use a quite similar technique after the harvesting of a scapular graft. This was performed in the patient with the oral cancer, and this is the situation after 1 year. So the patient is asking for prosthetic rehabilitation, but the scapula doesn't provide enough bone for installing the implants. So we have a very limited bone. It's vital bone. It's a nice rehabilitation, but we don't have enough height and enough width for installing the implants. So we're using hip grafts in combination with some bone substitute materials. In this case, it's max resorbate synthetic bone substitute material, and we are doing a large vertical and horizontal augmentation. Also here, we don't need a long barrier function. We just want to fulfill the expectations of GBR on the lingual aspect and some little contouring of the bone on the buccal aspect. And because it's an irradiated patient, we want to have something like an insurance if there is a wound healing disturbance in the healing period. And we get beautiful bones. So you see nice bone formation in the entire grafted area. No problem at all to install the implants. And the cold protect membrane provides a nice matrix for blood vessel ingrowth, but still some kind of barrier function to separate the graft from the surrounding soft tissue. Implant installation at the end, from the functional perspective, from the prosthetic perspective, a very happy patient. Some other indications, just consider you perform a sinus grafting procedure, you have a little perforation, or you just want to stabilize the membrane. We are using this technique as a technique for membrane stabilization. We call it the fish technique, but also here we don't need a long barrier function. You see these little perforations of the membrane. the fish is folded, the head is installed into the sinus cavity, and then the bone substitute material is applied underneath. And we know that we also get a little better results when we apply a membrane on the buccal aspect, so we can just, after rehydration, fold the tail of the fish over the grafted area, soft tissue closure. And for stability matters, this might be a little idea to immobilize the membrane inside the sinus cavity for perforations, or even if there's no perforations, and with the same membrane to cover the facial aspects of the sinus to protect this area from soft tissue ingrowth too. So when we go back to the old publications, where we evaluated different aspects, barrier function, we have learned that the biogap membrane has a very low barrier function. The EPDAV membrane, because it's completely occlusive, of course, had the longest barrier function. The cross-linked membranes have a longer barrier function than the non-cross-linked membranes, but this is not everything that we have to take into account. It's also important to look at the tissue integration, the angiogenesis, which is quite nice for the biogap membrane. A very nice tissue integration, a very nice ingrowth of blood vessels, with a zero, of course, for EPDAV membranes, because they're hydrophobic and completely occlusive. But also influencing another very important aspect, this is the complication rate. So we have a very low complication rate if we don't apply any cross-linking. And if we are using a non-absorbable membrane, you have to be very experienced in terms of soft tissue management, that you don't see an exposure after the application. When we want to install these two membranes that are provided by Botiss or Stroman, then we see a medium barrier function for the cold protect membrane, but still a nice tissue integration, and a focus on angiogenesis for the cold protect membrane with a low complication rate, because it's a non-cross-linked type 1 and 3 collagen membrane. The JASON membrane has even longer barrier function, but still, because it's a non-cross-linked membrane, good tissue integration, still some angiogenesis and a low complication rate. So we are coming to the summary of my little 60-minute webinar. And one thing that is, of course, quite obvious is that we can use different techniques for predictable alveolar augmentation. We can use autogenous bone, we can use bone substitute materials, we can use destruction osteogenesis, and all of these techniques have their advantages and also some disadvantages. Nevertheless, when we compare bone substitute materials and autogenous bone, we know that we can reach the same level of quality of the results and also reliability of the result when we're using bone substitute materials instead of autogenous bone, especially for localized lateral defects, and that was not the topic for today, sinus floor elevations. However, when we're using bone substitute materials, we have to be aware that also the soft tissue will try to invade into the defect area, and the principle of guided bone regeneration is a reliable tool to reduce this risk that leads to superficial soft tissue encapsulated bone substitute particles and vice versa, incomplete regeneration of the applied volume of the bone substitute material. We can use different membranes. The idea of GBR is completely fulfilled by the use of a non-absorbable, completely occlusive membrane, but they require high surgical experience and high accuracy when we are using them in our daily practice, because they are having a high risk of soft tissue descents and subsequent premature membrane removal. when we're using polylactide or polyglycolide membrane as an absorbable alternative, then we have to be aware that this material is degraded by the production of lactic acid molecules, which attracts inflammatory cells, which may compromise the soft tissue healing, which also may compromise the hard tissue healing based on a higher acidity of the surrounding tissues. So for collagen membranes, we see better results and lower complications when we compare them to the absorbable alternative polylactide and polyglycolide membranes. However, collagen membranes differ significantly in terms of quality and absorption time. And this is based on different tissue origins, different processing techniques, and different types of cross-linking, whether it's enzymatic cross-linking, chemical cross-linking using different chemical agents, or even no cross-linking and maintaining longer barrier function by the use of pericardium as a donor tissue. And it depends on your personal requirements, whether you want to focus on barrier function, that is perfectly maintained by the Jason membrane, or angiogenesis, that is focused by the cold protect membrane. And last but not least, this is all important for the smaller defects, but also for the larger defects. But for the larger defects, we don't see stabilization by the defect itself. We need to use specific techniques to stabilize the graft, such as pins, screws, the use of titanium meshes, maybe in combination with the collagen membrane, or even block grafts to immobilize the graft and increase the predictability in regions outside the envelope. Thank you very much for your kind attention. So, thank you very much for participating. I just check my watch. We have 2 minutes to go, so I'm quite good in time. Germans are good in time always. And the panel is open for discussion, so whenever you have a question, just let me know and I will respond to your questions. So hello is the first question of Jintara Grecien. What is your opinion about PRF membranes? So PRF membranes or PRGF membranes, for those of you who don't know what kind of membrane this is, these are membranes that are based on the idea of harvesting the fibrin from the patient's blood to separate them with a centrifuge and use it as a membrane. So that the name is quite similar, that it's a membrane because the morphology is like a membrane. However, when we are using these membranes, we have to be aware that the barrier function of these membranes is quite limited. So using it instead of a Jason membrane, for example, will not deliver the same results than using a Jason membrane in addition to a PRF membrane. We know today that PRF membranes are able to support the soft tissue healing. We are using these membranes, especially in patients where we have thin gingiva biotypes, for example. But just be aware that a PRF membrane will stay there for, let's say, maximum 7 to 10 days. This is not enough for a large graft with a bovine or a not bovine bone substitute material. So using a membrane will support soft tissue healing. There's still some doubt whether we can support hard tissue healing by the liquid or mixing it with the PRF membrane. But there's no doubt that the barrier function of a PRF membrane is not comparable to original collagen membrane. So what is your experience in the use of acellular dermal matrix? This is the abbreviation ADM, like mucoderm in GBR. So I don't use mucoderm as a barrier in GBR procedures. I think that we should do one step after the other. So the idea to use mucoderm at the same time when we are rebuilding the bone might be the idea to thicken up the soft tissue at the same time when we are building the bone up. Nevertheless, this is increasing the volume a lot. And we have another situation for the soft tissue thickening. So when we are using it at implant uncovering, for example, we're using a split flap. So we are using a mucosa flap, and the mucoderm is placed in between the periosteum and the mucosa. So we see much nicer prerequisites for soft tissue thickening than in the situation where we are using it instead of GBR membrane to separate the soft tissue from the hard tissue. So from my point of view, it's better to use it in a second stage surgery, that we are first rebuilding the bone. Of course, mucoderm might be material that can be also used for GBR procedures. Nevertheless, the handling properties are not as nice as the cold protect membrane or the JSON membrane. And then on a second stage surgery, we are thickening up the soft tissue when installing the implants or uncovering the implants. This will lead to a more reliable result in my point of view. I know some people are using mucoderm at the same stage when they're rebuilding the bone, so I wouldn't recommend that, because the prerequisites for thickening up the soft tissue are different if there's no vital tissue underneath. So Joseph Curtis is asking, are there any currently available membranes that you would recommend using without primary closure? That's a bit complicated. If you check the indications for all the membranes that are currently available for GBR procedure, you see that they all have to be used in a closed condition, because there's only data available for that. If there's a secondary opening of a wound, this is considered as complication, so you can't do anything against it. But if there is an open system directly after the surgery, you might end up in a contamination and complete loss of the augmented area. So I wouldn't recommend to use a normal collagen membrane in open healing setting. However, there's a new membrane that is a more occlusive membrane. It's called PermaMem. And with PermaMem, you have the situation that there's not a competition of the bacteria and the blood vessels to invade into the matrix, because it's not a collagen membrane, it's a PTFE membrane. And it seems to be the case, there's not much data about this, that you can leave it a little bit open and the surrounding soft tissue will still stabilize the site. So this might be a better idea to be used in an open situation than a collagen membrane. A JSON membrane is a very thin membrane, so for sure I wouldn't use it. Cold protect membrane also might not be the best idea. If you consider mucoderm, it might work better, but if you want to achieve a more predictable result, then maybe we have to go back to the non-absorbable membranes, like the PermaMem membrane that is serving as a real barrier and allowing for nice tissue healing underneath without the risk of contamination of the grafted site. So that were the three questions. I got some thank yous. Thank you for a super presentation, very informative. I hope it was not too scientific. I tried to also introduce a lot of clinical cases to just underline the idea of different aspects of using collagen membranes. If there's any questions, just write me an email. If you want to have a look at my clinical work, you're always invited to just send me an email and come to my clinic. And if you are from not too far away, you can also bring your patient. If you are from far away, just come and observe our work. We're doing a lot of grafting procedures using different materials. We are trying to develop new techniques. We are getting a lot of support from Straumann, from Botiss. And again, thank you very much. It was a great pleasure to transfer a little bit of the knowledge to you as the participants of this webinar. If there's no more questions, I wish you a nice afternoon, a nice evening, a nice night, a nice morning, depending where you are. And thank you very much for participation.